we're going to ask you to do in a clinical note. And the other one was what is going to be included in the clinical note. I think the example, if we get the example up here, it's easier to see. St. Joseph's Home Health has decided to go and outsource the coding and pre-review of the OASIS. Now, normally, all of your pre-review is being done by Sylvia and Deidre. And this is now going to be outsourced to a company. And some of the reasons for that is to be more consistent and compliant with the coding conventions that change on an annual basis, by the way. Thank you. As part of that process, you're going to be more involved. And I'm going to tell you why. If you really look at the rules of OASIS, OASIS has a one clinician rule. What does that mean? That means one clinician does the initial comprehensive assessment, answers the OASIS questions, develops a plan of care, answers all the OASIS questions. So that one clinician rule, now they could corroborate with others, but that clinician is the one who's responsible for answering all of the OASIS questions and completing the comprehensive assessment. We've been doing a little bit of babysitting and not being totally compliant with this one clinician rule. So in order for us to outsource this to Select Data, they are very compliant with their one clinician rule. They know what it is, they understand it, they're all OASIS certified, they have, they're all, the coders are coding certified, and in order to be compliant with them, we have to go with our one clinician. Right now, in all scripts, you have a dummy code in 1010. Everybody know what 1010 is? Reason for hospitalization. 1010. 1016. Changes in the past 14 days. You put a dummy diagnosis in that one. And 1020 and 1022, you put a dummy diagnosis in there. And then our coders just go through everything and magically populate them. In order for us to have this process done from now on, we need you to identify 1010, 1016, 1020, and 1022. On the template, I didn't put, and I probably could have put 1010, 1016, 1020, and 1022. I don't know why I took it off. But basically, 1010 is the reason for hospitalization. And it's to add the diagnosis the patient was hospitalized for. If not hospitalized, put NA. Because if they weren't hospitalized in an acute facility or a skilled facility, if they came from a doctor's office, they were not hospitalized. So that answer to that is NA. The second one is the diagnoses that are related to changes in the patient's condition in the last 14 days. So Deirdre, I'm going to ask you for a rehab change.
Could be a fall, could be incontinence, could be
Right.
pressure ulcer, I don't know.
Right.
Different things.
Let's say the patient had a UTI, and because of that UTI, they had a fall. They were dizzy, they had a fall. What's the diagnosis that started that? What was the change in that diagnosis? So that would be a UTI. Does that make sense?
Yes.
If they went into the hospital due to osteoarthritis of the hip, and in 2 days they come out with a total hip, what was the change diagnosis that they went in the hospital for? What was that change that now requires a treatment change? Wrong. That's a
Comfortable pain.
Total hip replacement.
It could be, oh, you're right, abnormality of gait, yes. It would be. Correct. I'm sorry, Sylvia, you're right. I'm thinking V code, I'm thinking V code, and it's not, yeah.
That's the aftercare of the total
Correct.
hip.
So the change is now that they've had the surgery, they have an abnormal gait. So that would be a good change that occurred in the last 14 days, which is why they need physical therapy. And pain could be another one, depending on the amount of pain.
Muscle weaknesses, those
Yeah,
two are
muscle
common.
weakness,
Yeah.
yeah. So you would, just free form, abnormality of gait, muscle weakness, and move on to the next one. What is our primary reason for home care? That is the answer to 1020. If they had a total hip, it's going to be easy aftercare. Aftercare, total hip. And that encompasses an awful lot of stuff. If they've had falls, and the falls are because of a specific reason that has a diagnosis, you might want to use that. Most of these you're going to find in all docs. They're going to be in the history and physical, they're going to be in the discharge summary, they're going to be somewhere there. You're not going to have to make these up. As a matter of fact, if you're thinking you're making them up, you can't use them. Because all of these 4 items have to be corroborated by the physician. And if they're coming out of the hospital, we can only use the diagnoses that are in the history and physical and the discharge summary. If they come from the doctor's office, and we have that little, these are all the diagnoses the patients have for the last 25 years. Those are the only diagnoses that we can use. We can only use the diagnoses, and if we don't use the diagnoses there, we have to have made a phone call to the physician, which I told them we're not doing, to say, hi doctor, does this patient have, because they're on this medication, do they have this? Any diagnosis that they have should be either in their discharge summary, the history and physical, or the problem list that you get from the physician's office. And the heritage patients have a really nice problem list. Okay. And so we talked about the primary reason, and then other diagnoses are the additional diagnoses that are appropriate for the plan of care that you are doing. Are there any questions?
How about without all docs? Is there some new patients that they did pay without all docs yet?
I was assured that you would have all docs within 24 hours.
It doesn't always happen.
Doesn't always happen.
Does it happen?
We were assured the computer would make life easier.
Well, yeah. I will work on the all docs, and if you don't get it, we will work on that with you. But generally speaking, they should be in all docs.
All docs has to work.
Yeah, that's the other
Most
stuff.
of the time, not all the time. I'm tired of getting tickets and get around them.
That's another thing that we have to work with.
I'll have time
What was
to
the
come
question?
in. Yeah.
Hey, Michelle, you're not going to be doing these.
That was, I was looking at the yeah. PT speech.
This will be
Unless
PT
you're
and
like
speech. Now, you might, you may do it on a research, but it's going to be different.
Resumptions of care.
On research and resumptions of care, you may. Yes.
So I have a question. So this is gonna be, are we gonna type out reason for hospitalization and then we're gonna put it in?
You're going to,
You're gonna have-
if you opened your email,
Yeah.
you were sent a template. Right, Harry?
Right?
And that template you can either download onto a file that you can plug into your computer every time you do one, or you could save it to your desktop so that you have it to copy and paste. Okay?
So just to be clear, in the clinical note, we're just writing the PT diagnoses like muscle weakness, gait abnormality, but then on the actual start of care ACEs where they have the diagnosis codes, we're supposed to add all of the additional ones?
Okay.
Or are they all
Debbie,
supposed to be typed in the clinical note?
can you, or Tina, if you think about it, in the assessment, now this is for start of care, resumption of care, and research. It's not for your routine visits.
Right.
So on the start of care, right now, you put the dummy diagnosis in. And then you usually write them either in the bottom of the diagnosis box or you put them in your clinical note, right?
Well, the dummy,
No, right?
can you
Question was about
define what the
emails.
dummy means? I'm not,
That means the code that they put in to hold the space.
okay, so that's the code that intake puts in, and
Yes,
then that's the
that
code
you put in to hold the space.
I just haven't heard dummy.
Oh, that's, we've
Yeah,
always
but
used
it's
it.
so generic.
It's not
I
even
think what she's asking is, she understands in the clinical note, she's using the template, and she's putting the abnormality.
And then you're going to put your summary right below it.
But what her question is, when they're filling out their assessment, they have those OASIS questions there, the
Right.
M1010, the M1016.
Right.
I believe your question is then, now, do I still leave the dummy code in?
I
or do
said yes.
Okay.
That, yeah. You leave that code that's in there. We're not asking you to change it. We wanted to make it easier for you, and we thought free testing the diagnoses that you determine are easy to put in a clinical note than for you to try and figure out the ICD-9,
Okay.
and in the future, the ICD-10 codes that would be required to answer all those questions.
So then how does it get corrected in the assessment? Is that what Select Data is gonna do?
Our clinical review specialists initially will be doing that. That process is the way it's going to stay at this point. It may go to another process at another time. But yes. Yeah, Select Data is not going to, my understanding is that they are going to put all the appropriate diagnoses in the appropriate box. If they do put them into 1010, 1016, 1020, and 1022, I will let you know, because the training for that is going to be held next Wednesday. So we'll know better, but effective immediately, because we know that there's going to be a backlog of what the current coders are going to be able to do, we're asking you to immediately start putting these diagnoses in. So your clinical note is going to look like this now. Bigger so they can see it.
Scroll down, just scroll down.
Oh, yeah, yeah, just scroll down. Yeah. So here's an example of the clinical note. Reason for hospitalization, encephalopathy, acute respiratory failure, etc. Changes in the FAS 14 days that within a diagnosis, the patient had acute respiratory failure, ESRD, and severe weakness. Primary diagnosis, other diagnoses, and then the summary.
So leaving the spaces in there is how you want it, is preferred.
You don't have to leave as many spaces, you don't have to. You
Okay,
can do it whatever way is easier for you.
just as long as everything's in
Yeah,
it.
I separated everything so that it was more clear for you to look at.
Okay.
I understand why we have to do this
Mhm.
on the assessment. I don't understand why we have to rewrite our assessment in narrative form.
Nobody said you have to rewrite your assessment in narrative form.
Well,
I don't know where you-
all this information is in the assessment.
Right.
And
Yeah.
also
So
in
why
the
do we have to
intake,
restate
the
it?
intake will
It's
put it in,
redundant.
like, you know,
Look
the
at
reason
something.
and on the clinical note, when you get a patient, they have like a, you know, inpatient discharge and, you know, admission date and all
Right.
that stuff, so.
Right.
I know.
Whatever way you were told to do your clinical note after your assessment, because I know those assessments just re-rolled out, you can do that. Nursing does a summary. And this is a very nurse-centric example. It's not a therapy, it's not particularly a therapy. And when I sent it to Harry and Steve, I said, pardon, this is very nurse-centric, but at least you get the idea. Because nursing always puts a summary in.
Well, we do put a summary,
Yeah,
but
we
we
also-
were also,
Yeah.
but we were also told not to repeat all the
We don't want
diagnoses
you to
that have already
repeat.
been repeated
Oh,
in the
you
previous
can't-
clinical note.
Okay, we cannot take the diagnoses from intake. We cannot take the diagnoses identified by a liaison because of the OASIS one clinician rule.
So on the first clinical note, the intake note, there will be, what will be there? 87?
They're not gonna change what they're putting in. They're not gonna change, but because of the OASIS one clinician rule and to be compliant
Right,
with the regulation,
right. I get
the
that.
clinician that does the initial assessment, comprehensive assessment, and OASIS has to identify the diagnoses that need to go into these spots.
I understand that. That's in the assessment.
It's not in the assessment if you don't put it in.
No, if we put it in the assessment, I understand that, we put it in the assessment, and now we
Where do you put
rewrite
it in the
it.
assessment?
Medical history.
We have to tell them you can't put it in.
Right.
But that's not identifying that these are the diagnoses, because not all diagnoses in a medical history will go into 1020 or 1022. Yeah. If you're putting it in the medical history, you're not identifying what specifically has to go into 1020 and 1022.
So the coder doesn't add any diagnosis to what you identified yourself then. So they're just gonna input the numbers, the ICD-10 in it, but
What they will do is they will turn around and they will say, from what I see in all docs, what I see in the history and physical, what I see in the physician's notes, that this is a more specific diagnosis. They may do that. Because they're gonna be sending us back a query. And the query or a suggestion, you know, this is, and sometimes it's gonna be fine. And more for rehab, it's probably gonna be more fine. In nursing, I rarely see them saying it's fine. I usually see them making other suggestions.
So did you say if they come from a skilled nursing facility, the reason for hospital, we would put NA?
No, no, I said if they're coming from an acute facility or skilled nursing facility, because that's what 1010 asks.
Okay.
Were they recently discharged from a skilled nursing facility, or well, that's,
Skilled hospital.
right. Any of those, if they came directly from the community. Now, say they went home and nobody ordered home health, and they went, in 3 days, they went to the doctor and the doctor said, I need home health. If they were discharged within 14 days from a facility,
NA for observation too.
yeah, and this is just only because I know the OASIS questions, and a lot of times when you're doing them all the time, you don't read the questions. And if you read the questions, what they ask you are specific. Yes,
I just want to be sure, the ER is not a facility, correct?
correct.
Okay.
Is inpatient,
It's
they wanna know
inpatient.
about inpatient, so I think
So-
Dawn was gonna talk about how the observation unit is not an inpatient.
Right, so it would be NA for recent hospitalization, and then you would
If
put
the patient
codes-
just went in the ER and came back home, yes, that would be
And then the
NA.
codes would go into the
Correct,
change in 14 days.
correct,
Okay.
yes.
The M1016, a change of condition in the last 14 days, that one, can you have more than one? Can you
Yes.
say, okay, so. it can have the
Absolutely, and
amount.
usually you
Okay,
do.
Okay.
Yes, it's just like the reason for hospitalization, oftentimes there's 4 or 5. I know in some histories and physicals or in discharge summaries, I see 6 or 7. But you can put as many of them as you want, but prioritizing. It's always prioritizing to the most appropriate ones that need to be there.
So if we're doing like a PT start of care, like say for instance we get there before the nurse, does the nursing put their own diagnoses then, or how does that work? Like if they're doing
Yes.
labs and they're doing.
If they're doing an add-on, they will need to do it as well, only because theirs are not gonna be considered. They would have to corroborate with you.
You need to let the nurse get out there first if there's a chance.
Well, that doesn't always happen.
I know, but I'm
That's
just
the
saying.
problem, what we have right now
I
is that
get
nursing
it,
is the
I
noise getting
know,
out.
but my point is, that we better.
And by the
be-
way, if the patient has an infusion or if the patient has a same-day admit, the evening nurses are doing full OASIS assessments now. Just for you to know. So if you go out the next day, the OASIS will have been done.
The other thing that I could offer is that if, for whatever reason, you can't see all docs, but it's in host, you can call us and ask us,
Yeah.
Steve or myself. So we're happy to convey some of this information if, for whatever reason, you can't bring up all docs.
And like, Yeah, I was gonna say like any,
Good question. When we get our weekend supervisor position filled, we might be able to get you some help, but I